All right, so let's talk a little bit about how we can maximize patient participation, how we can encourage patients to make informed choices about their treatment options. So probably one of my biggest pet peeves is hearing push people to go home. Please, just stop that whole language. It's not about that. It shouldn't be about that. We want to make sure people have the education and information to be empowered to make an informed choice about their treatment options, right? So I did CKD. Yeah, thank you. Thank you. Yeah. One of the most important indicators of being successful at home dialysis is motivation. The person's motivation, not ours. Not ours. It's their motivation to go home. If they want to go home and do home dialysis, they will likely move the world to be able to do it. If it's just us wanting them to go home, you can almost count on it being an unsuccessful train, right? We know that though. So we start with education, and I don't think this is anything new to any of you. Education, when I talk about it in 3 domains. It's really about staff education. We have to make sure that we're educated enough to provide patient education. That's a big deal. I talk about it again in patient education. We have to have the tools and the motivation to want to educate the people wanting to go home. And then we have to have what I'll just do one lump sum is facility education. Our providers need to be educated about home, and our leaders need to be educated about home, and our other ancillary staff and in-center staff, they also have to be educated about home dialysis. It just won't work any other way. And then it's about assessment, and it's about a comprehensive assessment. The assessment is lengthy. It's not easy. It takes time. We have to assess people at their educational ability, their learning styles. We have to remember about the principles of adult education. We have to assess their physiological needs. We have to assess their psychosocial barriers. We have to assess their cognitive abilities. We have to assess their vision. We have to assess their mobility. So this is a big assessment that we need to do. It's not really a short assessment. We have to assess the home environment, right? That's important. I see a lot of things now where you really don't have to assess the home environment before they start on dialysis, which perhaps is true because we can alleviate a lot of barriers, but it sure is beneficial to know what you're working with before you get started. That's very helpful. Training. Well, that's kind of like, of course, we have to train the patient, but there's different training styles, and we're going to talk about that. And then we're going to talk about retention, because we can train all the patients we want, but if we can't retain them, that's a bit of a problem, right? We have to be able to retain the patients on home dialysis, if that's where they want to be, right? We always have to remember that, if that's where they want to be. Why home dialysis? Anybody want to tell me why? Say it loud, say it proud. It's the best, but why? Yeah. Okay, all right, we've got a lot. We have better outcomes, we really do. We have better physiological outcomes. Some people who do home hemodialysis, I'm going to show you some stuff about home hemodialysis, by the way, that if you haven't seen it before, it might just blow your mind. It did mine the first time I seen it. But some people on home hemodialysis, especially nocturnal, have better improvement in their phosphorus, bone mineral control. They have more better outcomes in their fluid management, doing more frequent dialysis, whether it be peritoneal dialysis or home hemodialysis more frequently. They may have better outcomes in their anemia management. The psychosocial outcomes are pretty huge, right? You don't have to miss all your social gatherings anymore, and you don't have to argue with anybody about what time your treatment's going to be. As long as you get in the number of treatments across the time span you need, you're doing okay. So you don't have to pay for all those transportation costs, so it's cost effective for them. If you take less medications, because some people have a decreased pill burden with home dialysis, it's more cost effective. You don't have to pay all those co-payments for medication, And you might be more likely to take your pills if you're not on 25 of them in the morning and 16 at night. So you might have better medication compliance, and you might have better outcomes because people are actually taking their medications. Some people on home hemodialysis and peritoneal dialysis, because they have better fluid control, they are able to take less blood pressure medications because they don't have all that extra fluid on board. Empowerment. I cannot tell you how proud, well, you already probably know if you work in home, people are proud when they get to go home and they say they did it. They're proud that they can do and engage in self-care, and this is a big deal for them. Empowerment of self-care is a big deal. Once people in home dialysis, we have an amazing ability to work this close with people. So close, you can educate them about every aspect of their disease process in a way that they can understand and use. They can understand and use. We can dump all the education in the world on them, but if they don't understand it and they can't use it, it's useless information. But we can work so closely with them to get them that education and information, and that's important. We have to do that. So survivability rates for nocturnal home hemodialysis. This is what I'm talking about when I say it's huge. The bottom little blue line there, or big blue line, purple line, I don't know, the bottom line, that's in-center survivability over a 10 years. 10 years. So then we have the gray line next, that is peritoneal dialysis. So we're looking better. When we talk about outcomes, 10-year survivability is better with peritoneal dialysis than it is with in-center dialysis. That's a pretty good thing. I have a lot of people ask me, how long am I going to live on dialysis? I refuse to answer. Well, there's a lot of variable factors too on that because, some people who start dialysis at 93, their life expectancy wasn't 10 years probably to begin with, maybe, but maybe not. So, there's a lot of variable factors. But those top three lines, the green or yellow one, I don't know, I don't see colors all that great, but that one's a deceased donor transplant. The red one is nocturnal home hemodialysis, and then that upper purple one or blue one, whatever color you want to say it, that's living donor transplant. Nocturnal home hemodialysis is almost a good of 10-year survivability or as good as transplants. I don't understand why everybody's not doing nocturnal while you're sleeping. I do, but look at those. That's pretty crazy. And here's one to think about. I heard this before at conferences, but it always strikes me a little bit scary when I see it. These are 5-year survivability rates in compared with cancers. So the red lines are kidney disease, people who have kidney disease on dialysis. The first red line is 5-year survivability rate for people who are in-center dialysis. They have a 5-year survival rate just a little bit better than cancer or brain cancer. They don't beat by much. And then the next one's peritoneal dialysis. So we're making some gains in 5-year survivability with peritoneal dialysis. Those two upper red lines are living donor transplant, which is the highest. Then there's a purple line that is eye orbital cancer. And then the next red line down, if you can't see it real well, is deceased donor transplant. So if you put in the nocturnal home hemodialysis, they probably have a 5-year survivability rate, I would say about the same as the deceased donor or the eye cancer person, which is pretty good survivability rates. It's a big deal. And this data is collected from the USRDS, the United States Renal Data Set. So it's available for anyone to review. There's so much data on there. It's crazy. It kind of makes your head spin a little bit, but it's good information. And somebody said, well, how do we know how we're doing? And that's where I always look. The problem is it's usually a couple years behind.